May I welcome Dr. Colin Brown, Andy Wicks, Mel, Mel, forgive my pronunciation, is it Waszkiel?
Waszkiel.
Thank you. Laura, Neal, Rob ONeill, and Marc Hadwin. I have to say, I have been treated by Andy to the pitch that he did for this presentation. I am so excited. I think it's got amazing national and international learning opportunities. Colin, it's always a pleasure to speak to you. You know, I have an immense fondness, although I'm not home in Kendal at the moment. I will be next week. I'm down in wet Windsor. I'm going to waste no more time other than to say thank you all for taking the time to prepare. Thank you for being part of Fab Change Day. Colin, if I may, I'll hand over to you. I'll go on silent. We'll listen out for questions and jump back in towards the end of the hour, if that's all right.
Lovely. Thanks ever so much, Shane. So I'm Colin Brown. I'm Chief Clinical Information Officer for Moorland Bay Hospitals. And this morning, my team is going to share our experience with setting up and providing clinical COVID testing services in Moorland Bay, providing information services for those COVID test results, and also automating those services with robots. I'd particularly like to thank the Fab NHS Academy and IHM for all the support that you've given Magic Moorland Bay over the years, and particular thanks to Roy, Terry, John, and yourself, Shane. Next slide. So here's a scene in the Lake District which kind of depicts a journey that we've been on in respect of our IT department. And I'd kind of like to share with you some key principles which have helped to guide our department over the years. And these, picking up from a theme from the previous presentation, these revolve around people. It's service, it's customer care, it's looking after people that is the really important thing. And the gentleman on the left is Steve Fairclough, who was our head of health informatics for a long time, from 1993 to 2015. And Steve had two key principles. One was to always say yes to reasonable requests, even if it was difficult. And then Steve and the team would come together, huddle in the IT department, fret a bit, design new solutions, and then deploy them with the users. And the second principle was to kind of walk in the shoes of others and to try and improve their lives. And an example of this is going back to 2012, when our infection prevention nurse team didn't know where their patients were, didn't know where the infections were across the three hospital templates. So in our Lorenzo EPR, what we did was to design with our IP nurses that if they inputted alerts into patient records, for anyone in the population, wherever they were, in respect of having a positive result for an MRSA or a Clostridium difficile infection, then if that patient was then subsequently admitted to the ED department or an inpatient ward, that patient would trigger onto a digital work list. And the lives of our nurses was transformed, and actually patient care was a lot safer. The gentleman on the right is probably well known to many of you now. Paul Charnley of the Wirral and Cheshire was actually CIO with us in Moorland Bay for 18 months from 2015 to 2016. And Paul always advised that we should treat critical feedback as gold dust, because it gives us an opportunity to improve. And we kind of that principle recently in substantially improving the user experience for our EPI users, working in collaboration with class research. So a key principle there is listening to people. So I'd now like to hand over to my colleague Andy. Next slide.
Hi, I'm Andy Wicks. For 4 years I've had the privilege of being the CIO. Over the next half an hour or so, four of us will describe how we establish local COVID-19 hospital command centres, mobile device of those staff that need to do them. And finally, you'll hear how we extended this process to include antibody testing and some clinical trials, and at the same time, how we streamlined the process with robotic automation. First, though, I'd like to take you back to the early days of the pandemic. The photo on this slide is the sun rising over Moorland Bay in early March. I remember taking this picture and enjoying the sense of calm I felt standing on the hill, looking across the bay. And I chose this photo because of that, to help set the scene, because as you remember, in the early days of the pandemic, it was anything but calm. In the world of digital health, we were all extremely busy establishing COVID-19 command centre infrastructures. New wards are being set up and existing wards reconfigured with additional equipment. We tripled our capacity for inbound and outbound telephone calls and support primary care to shift incredibly quickly to a system of total triage. We also supported a major reconfiguration of the hospital outpatient clinics and began to explore new tools for video consultations and the transfer of digital images directly from our patients. We also have numerous, often daily, new requirements for national and regional reporting, and there was a massive effort to establish thousands of staff to work from home, including 85% of our own department. We also enjoyed facilitating our organisation's surprisingly easy move to this new era of online meetings and use of our intranets. And it's with this backdrop that our organisation decided to establish a programme of local testing within Moorland Bay to help keep our colleagues and other key workers safe and to minimise the time they had to spend away from work self-isolated. And this is where today's story begins. I'll hand you over now to Mel and Laura. Next slide.
Hi, I'm Mel Waszkiel, Head of EPR Programmes, and I'm presenting with Laura Neal, the Associate Chief Nurse for the Trust. And we will explain how we implemented COVID swab testing here in Moorland Bay. Next slide. At Moorland Bay, we started testing in mid-May with an ask to provide a service for all key workers in South Cumbria and Lancashire, which included Cumbria and Lancashire Police, the fire service, teachers and care home staff. And this was at the Royal Lancaster Infirmary. It was initially a paper-based system, with ONeill Health taking the referral and documenting the person's details on paper before it was sent by a runner to another building to book a swab appointment on the EPR system, but it was a very much paper-driven process. Results were added to a spreadsheet, but with numbers so low, it was fairly easy to keep on top of. And we were sending letters to the GP electronically with the results and also adding an alert to the patient record if they were found to be positive. At this point, swabs were being sent to the Public Health England lab in Manchester, so they were taking a while to be resulted, and we had to log into the PHE portal to retrieve the results, although they were eventually being fed into our lab system, but it was all taking time. Next slide. By March, with numbers rapidly starting to increase, the paper-based referral system was causing bottlenecks. We were literally shuffling paper from building to building and tray to tray, and then a second swab centre was set up at Furness General Hospital. Towards the end of March, Preston were able to process our results. The turnaround of results became much quicker, but we needed to streamline. So we switched to Microsoft Forms, which populated a spreadsheet in Microsoft Teams and meant that it was much easier to keep track of patients, but the resulting aspect was difficult and time consuming. We were ringing patients whether they were positive, negative or tested failed. And we had fantastic teams running the appointment system, swabbing and resulting to try and get people tested and resulted in a timely manner. But using spreadsheets meant that we felt that we were drowning in data and one false move could have serious consequences. Next slide. At this point, the information team stepped in. It was my mission to get rid of the spreadsheet. And they created a ClickSense app so that we could filter results much more easily in real time as they were processed in the lab and then viewable in the app. This meant that we could easily report on different patient groups and we could keep track of who'd been contacted, and this enabled rapid expansion. In April, a third swab centre was set up in Waszkiel General Hospital and we started to screen care home residents. In May, we were asked to set up antibody testing, which created a huge surge in demand, and with a bottleneck again, trying to provide results to people. At this point, the robotic process automation was brought in for COVID antibody testing, which revolutionised the whole process. Staff could now book their own appointment using an NDL form associated with a database of appointment slots, which was a move away from the Microsoft forms and meant that we could result them by text or email within 24 hours. Next slide. So the scores on the door, we've now performed over 30,000 swabs and nearly 13,500 total of antibody tests. Next slide. So to summarise, this is how it started and this is how it's going now. And I'll hand over to Laura, our Associate Chief Nurse, who will tell you about the operational leadership and patient perspective.
Thanks, Mel. Hi, everyone. I'm ONeill. I'm the Associate Chief Nurse at Moorland Bay Trust. I'm delighted to be here today and share our journey, how it started and how it's going with digital technology during COVID for our patients, staff and key workers. Looking back at the beginning, we didn't know what was coming our way. However, what we did know is that we had the right people, the right skills and the right resources. At first, paper-based spreadsheets was a comfort. However, we realised quite quickly that we needed a crash course with digital Microsoft to be able to deliver at pace. The call to action was real, with staff, patients, key workers, all looking to lead them through complex, fast-moving reconfigurations with no instruction manual. With the nervousness of PPE, fear of COVID, unsure demand, setting up services such as screening, swabbing, scrub hubs, clinical and tactical demand, just to name a few. In short, none of what we achieved was enabled by one, not 10, but the whole organisation. Like most services at the start of COVID, there was hierarchical command and control systems, and the reality is that this can increase stress and the health and well-being of our staff. Moving from the mountain of paper to digital forms and processes facilitated a systems multi-level leadership approach that started to reduce our stress with headroom to think. Staff were flourishing with autonomy, with a sense of belonging and contributing then despite the pressures of daily hourly demands. By no means have we arrived at perfect. However, we are a huge distance away from where we started. To ensure people and staff were cared for in a safe and caring way, as Mel explained, the screening appointment system rapidly evolved as demand increased. This permitted a reproducible system that at the touch of our fingertips we could adapt, for instance, setting up an antibody service within a week. Having those suite of tools, click apps, reduced our stress levels. In the height of the pandemic, we didn't have time to write up notes or reports. We also realised it was a great audit governance tool that, for instance, couldn't be lost or blown away like a piece of paper could be. To say the move from paper to digital in the hardest time in the NHS was easy, it wasn't. However, knowing the impact on patient experience is rewarding in itself. I'm just going to share with you a few examples that we've received from staff, patients and key workers who have used our services over the last few months. There was a prompt professional service. I felt nervous but safe. And just taking you back to Mel's slide earlier where the total swabs performed with scores on the door were 30,000, this person said they was treated as a person and not a number. So I think that's really significant. They felt listened to, the service ran like clockwork, they were seen within the hour and indeed even described as a wonderful experience. This is really some achievement in challenging times that is described overall and summarised as kind and compassionate. We are human. However, the robot who makes this look so easy connects us to do something really important. It helps us to hear our patients, staff, key workers, to express how they feel safe in our hands with our NHS. We now find ourselves back in the resurgence with limited time to recover. Having those suite of tools, the click sets, the data set apps, ensures essential time is released for our staff to care on the front line. Digital technology for us during COVID has enhanced and supported and improve patients and staff experience. When we look at the mountain of paper on the left-hand side of this slide, from where we started to where it's going with the robot on the right, it is obvious that we are usually enabled by digital technology and not paper. I'm now going to pass you over to Rob ONeill. Thank you very much. Next slide.
Thanks, Laura. I'm just going to share my screen again. My name's Rob ONeill. I'm the Head of Information at Moorland Bay Hospitals. And I'm going to talk you through our journey of using data and analytics to support the organisation through the coronavirus pandemic, with a focus on rapidly implemented analytical solutions that really shone a light on the organisational pressure points and clinical priority processes. Our mandate was really simple. We had to find the data we needed, integrate it, analyse it, forecast with it, and present it in a way that enabled staff to derive insight and take action. And we had to do this in real time. I can break down our support into 4 domains: operational, clinical, executive, and central, regional. Operationally, the key solution that supported staff was our Click Analytical Command Centre. We built this and deployed it last year. The command centre is both a physical space that allows users to track the live and predictive flow of patients throughout the hospitals in really, really large scale. And it's designed to work a bit like an airport traffic control centre. And also it's an app that staff can access through either their mobiles or laptops. Clinically, we rapidly built a suite of apps that supported clinical workflow and decision making, and aligned with Mel and Laura to deliver this. There's a lot of talk of digital enablement and buy-in being one of the positives that have come out of the pandemic, and our successful deployment of clinically focused analytical solutions is a really good example of this. In terms of the executive mandate, there was an urgent requirement to help our executive team make sense of what was happening on the ground and to establish robust reporting frameworks that supported the regional response and calls. Again, the automation of analytics reporting was key to meeting this requirement and delivering fully up-to-date analysis in a rapidly changing environment. And centrally and regionally, the demands on healthcare providers to supply accurate data of what was happening were obviously high, and they continue to be so. We addressed this by both partnering with our tactical and clinical teams and by also automating the flow of data. Our Click Analytical Command Centre formed the foundation of our operational response. The key requirement was to integrate new live data flows for COVID-19 screening and results into the solution, and this meant we were able to give our operational teams an at-a-glance view of the volume of patients with either suspected or confirmed coronavirus, where they were located, and a drill-down functionality to the patient record level. As the pandemic accelerated throughout the UK, we worked with a commercial partner, Catalyst IT, to implement the command centre within 7 London hospitals, and this included the NHS Nightingale Hospital in London. It took around 3 days to implement, and the ability to be able to lift and shift the solution into other healthcare settings was critical. We also augmented the command centre with a suite of operational apps that focused on tracking live cases across the community or within the walls of the hospital sites. The focus was on rapid and agile development and deployment. This is the command centre. I'm going to give a live demo of this in a few minutes' time. Clinically, as the pandemic hit, we had to rapidly review existing data flows. That's the content of data, how quickly we got it, the timeliness, our processes for extracting data, loading it into our data management systems. And that became essential and really became the foundation of our ability to respond with speed. A significant challenge for us was that our clinical systems just weren't set up to record everything that was required. So that could be whether a bed had a ventilator, whether patients were receiving oxygen or ventilation, whether a patient had an alert set up which confirmed a positive diagnosis, and so on. So we needed a really quick way to augment our clinical systems, record additional data, and that was required for both clinical management and national reporting. This led to a change of focus. We used to think about dashboards in terms of business intelligence, and now we think about solutions that drive action. And a great example is the creation of apps that include what we call write-back capability. This is where users can both consume analysis as well as record additional data that in turn can be augmented back into the analysis to provide additional insight, additional context. One of the apps where this worked really well was the one that Mel and Laura have talked about, and that's the Teams alerting safety check app. So this looked at patients that had been screened and what their result status was and whether their clinical records had been updated. The value of the solution to me is not only does it provide detailed information at a patient level, it allows a clinician to record additional data associated with the patient, how they're being managed, and importantly, it acts as a guardrail for clinical care. This is what the alerting app looks like, and again, I'll give a really quick demo of that in a moment. In terms of executive support, providing a clear line of sight from the board to the ward was a key requirement. We think of this as joining the dots from an operational and clinical reporting and rolling this up into board level metric driven insights. And for me, the requirement from the senior team was really stark. They needed to have clarity and be guided through the noise of what was a messy, complicated and ever changing situation. On-demand analytics that could be accessed anywhere and through any device was critical. The use of geoanalytics was particularly important in terms of helping our healthcare system understand the extent of COVID-19 screening, uptake, and confirmed diagnosis. And our out-of-hospital response teams utilised live mapping functionality that we built to risk assess patient cohorts and implement effective triage and assessment processes. As Andy mentioned before, the requirement to supply accurate data feeds and situational reports into regional and national teams was intense, sometimes overwhelming, and the requirements were often changing on a daily basis. I'm okay with this, and I fully recognise the need and the value of having regional and national command and control frameworks in place during this type of situation, but it is a topical subject. I do want to iterate that we reaped the rewards of having a really clear analytical strategy, which involved investment in industry-leading data management and analytics solutions. And with this in mind, I'm going to finish where I started before jumping onto a quick live demo. Our mandate in response to the pandemic was really simple. We had to find live data the organisation needed, integrate it, analyse it in real time, forecast with it, and present it in a way that meant our staff could derive insights and quickly take action. So I'll jump into a quick live demo. I'm going to quickly show you our Click Analytical Command Center. So anyone in the organisation can access this by typing command into their web browser, but I will show it to you here. So this is our command center. This is giving me a live and predictive view of what's happening within the hospital sites. Each one of these screens, tabs, represents a screen, a physical screen on the wall of the hospital. It also represents a sheet within the app. So just to orientate ourselves within here, I can see that at the moment, we've got a number of ambulances which are on their way into the hospital sites. Any one of these objects within the app, I can click on and get some more details. So if I was looking at a patient record, which I'm not, I could have a look at detailed information in relation to that patient. I can see here some ambulances arriving. I can see what the patient has been brought in for. I can see the estimated time of arrival and so on. And I can just, what I want to show you is the how we integrated screening and positive diagnosis data. And like all live demos, that's taken a while to load. So I'll jump into the app which Mel and Laura talked about. So this is a live app that's integrating data from our screening systems and from our EPR and providing a digital guardrail for our clinical teams. So a bit of context at the start of the app to allow the clinical teams to navigate how to use it. And then I will click on to this page. And this is I've stripped out the patient detail. This is showing you that we give the clinical teams a patient record level view of which patients have been screened. I can filter on this if I want to, so I can look at whether a patient has a positive or negative screen. And importantly here, I can record what action I'm taking. So as a clinician, I might want to record that, yes, a GP letter has been sent to the patient. Yes, I've created an alert within our clinical system. And yes, I've contacted the patient and informed them of the result. If I save this, it writes it back into the application, and you can see here where this has been done. So this presents the digital guardrail and clinically focused app that Mel and Laura talked about. And with that, I'm going to jump back into the presentation and hand over to Marc Hadwin to talk about automation.
Hi, thank you, Rob. Hi, my name is Marc Hadwin. I'm the head of digital services at the hospital. And as Rob's introduced there, I'm going to talk about how we automated our COVID antibody and swab testing. I'll talk you through some of the technologies that we use and how we were able to implement it in fairly quick time and also adjust the processes as we went along. Let's go on to the next slide, please, Rob. Okay, so I got involved with the screening hub really as Mel said earlier when the volume started increasing. Initially, it was with the antibody testing service, and it sort of synchronized really at the same time as when the Siren research project was going live. So, and as we were able to get more involved with the screening hub, we were able to offer, I suppose, like an increased menu of support, really, as Rob, Mel, and Laura have all described. And what we're able to do, and we still are able to, proactively offer support. So that, the challenge we were set was reduce the admin bottleneck, provide a system or a solution that was safe, simple, sustainable, and scalable. We didn't really want to create something that, as I think we're all expecting, the numbers, particularly of swab testing, to increase, and we didn't really want to create a service that would have, I suppose, an ever-increasing admin burden or admin demand. So the challenges that were set to us were fairly clear from the start. Next slide, please. Okay, this is the right slide. We follow the USA approach, which is understand, simplify, and automate. We'll change the logo there. And this process is fairly simple, really. A patient was a clinician, so they can do that together and have a result, which goes back to the patient. There's a few other considerations to take place here as well, which are namely, to-do lists, patients who maybe don't have a mobile phone number or an email address. Patients, part of the process as well is contacting patients who've had a positive result, contacting them on the telephone to discuss their results. So we're providing lists and information back to the COVID screening hub to help them support their patients. Okay, if we just go on to next slide, please, Rob. So breaking down that process, really what we looked at was the building blocks that we would need to provide this service. And working in sort of reverse order of these, there's a small database really where all the data is held and all the processing takes place. The front door of the service or the system is an e-form, which is we built through our NDL tool, and that is simple, easy to use, and probably as important, it's quite a pretty form as well. At the heart of the system is a robotic process automation, which is we've used Blue Prism as our RPA client, and that does a lot of the effort work that previously admin staff were having to do. And then providing information back to services of operational reports and some audit as well of the information that's going through the system. So those were the building blocks, and really the challenge was to get those building blocks in the right order to support our process, our simplified process. If we just go on to the next slide, please. Okay, so I think, choosing my words carefully on this slide, really, nimble, I think is probably a good word. And also we've used need, I think, rather than requirement. As Laura said, there's no handbook for this at all. And a lot of it is learning on the job and being close to the users, close to the screening hub in this case was absolutely key for us. So we were able to apply our technology to the process, and that was it was pretty rewarding, really, for I think all concerned, as we've said before. Other challenges that appeared. So I think we have about an 85% coverage of patients in the area who have mobile phones. So there's obviously 15% of patients don't have mobile phones. So we had to create some additional processes there for patients maybe who are having surgery, for example, in the hospital, but live outside of the area. And I think one of the things that was successful, really, we were able to modify and adjust our processes quickly, i.e. same day in a lot of cases, as needs arose. As Laura said really early on, there wasn't really the time to sit down and work out an end-to-end process. We sort of all had to get stuck in and just do what was needed to be done. If we go on to the next slide, I think I'll show you the form in action. I'm a bit of a chicken, so I'm not actually going to do a live demo. This is a video of the form being filled in, which isn't without risk, I will say as well. I think what we found from the e-form that we've offered out to people to use is one of the things that we've been able to do is validate the data that as it goes in, which sounds fairly obvious, but you can see the mobile phone going in there. That actually is a valid mobile phone. It won't let you put an invalid number in. And also if we can collect some other information about your condition, are you symptomatic, asymptomatic, which organisation do you work for, as in this case it's a UHMB staff member, which care group, which department, which site, and also some other questions about if you're patient facing. We also have an option here to join the K9 study, which is an associated research study, and then actually onto the final page where you just basically book your slots. So you can, if you're unable to make it into the hospital and need testing at home, you can choose home, but for this sake we'll just pick a date and a time of when we can come in, and those dates and times have changed as demand and approach has changed as well. Okay, and then you get a little confirmation to say that your request has been successfully submitted. You would receive a text if you put a mobile number in, or an email back to confirm your appointment as well. So we've got another video on the next slide, which is hopefully our robot, which is going to pick up all of that information. It does go pretty quick, as you can see. We didn't really get much time on that first screen, but what it's doing is picking up all that information and keying it into our requesting system, which is a system called TQuest. And what we'll see in a second, it'll pick the COVID-19 screen, which is part of the microbiology group. Now it's asking for which staff group, so it'll pick UHMB staff, and then it'll save that test. So it takes about 45 seconds to a minute for each one as it goes through. So it cranks through these in quick time, and we have it running all day really. So that as test requests come in, they're just immediately placed onto our requesting system. And that then creates a clinic list at the end of it as well. And it's now closed, so we can go on to the next slide. So this is some of the output from the system. So at the very top, you can see that's a confirmation for a booking of an appointment. The briefly enlarged mobile phone is a result of a swab test. And at the bottom, a slightly more detailed result of a swab test, where we're obviously not limited to just a couple of hundred characters as a text. We can elaborate a bit more, and we've chosen to include a link to the government's website on the latest guidance. So that's been pretty useful for us, because it's allowed us to keep abreast of the fairly quickly changing guidance without having to put a lot of effort in. We can just change a link, or we can update a link, and we can include things. So and as I said earlier, I think one of the parts of that process is if the patient has returned positive, then the COVID hub will ring them up and discuss their result with them. So just move on to the next slide, please, Rob. Okay, so just a few numbers and stats really of what the robot is doing at the moment. So it does well over 200, probably 250 tests per day. The bulk of those are virtually zero admin. Actually, the only real admin that's required is printing the labels out and putting those on the tubes to send to the lab. So we think that saves us over 50 hours a day. It's probably significantly more than 50 hours a day, but I think we're all comfortable with that as a figure, because we're not having to use computer systems as much. We're not having to certainly telephone the patients with negative results. 95% of our results get reached back to the patient within 24 hours, and 100% of positive results are returned within 24 hours. Okay, we'll just go on to the next slide, please. I think this is my last slide. So we've got a couple of more sort of stages really to our service that we're looking to implement. One which is we're calling closing the loop. And by that we mean enabling the patient to confirm that they've received and read their result, either by text or by email. So that's ongoing at the moment. And the second is care home access. I think we touched on that earlier, where one of the things that we're trying to do is really cut down to the absolute minimum, the time that it takes us to get results back to care homes. So we're looking at how we can give care homes access directly to the system, so they can get their results returned to them, as quick as absolutely possible. So those are our next 2 stages. And I think if we just go to the next slide, Rob, hopefully this will be the, I just want to say thank you on behalf of myself and everybody else, but I'm not sure how much time we have for any questions, but I think that's our slides done.
Well done, Marc and team. And we've got a good few minutes for questions if anybody would like to. We'd like to type them in there. We're looking out for them. I mean, firstly, may I congratulate you all. May I thank you all very much for your contributions this morning. I thought it was really easy to take in what it was that you were saying. And while we see if the audience would like to make some questions, a few observations, if I may. I mean, I've had the great privilege of meeting the team several times and touring with Terry and Roy across the different sites, and we were absolutely bowled over by the command centre and the presentation that you gave us last time we were up. So we've had a bit of a heads up, but the speed of change and adoption, the use of what you did is incredibly impressive. And there's a couple of bits I want to come back to that Laura and Mel said particularly, but Marc, while you're in the chair, I don't know if you can talk about the 7 hospitals in London that have already taken some of the learnings and adopted things.
Sure. It's Rob, Shane. I think I'll pick that one up. I mean, it was a really good success story. I think being able to respond and help the national response with the command centre was fantastic. I think it was. It was really painless, actually. I think it kind of shows to me the value of us within the NHS partnering with commercial organisations to do this type of thing. So we already had a relationship with our partner company, and it was really a sort of lift and shift in a bit of configuration, and they were up and running. A smooth experience.
Very good. How did that actual practicing of the the knowledge of how did you promote that, and how did those 7 hospitals know to sort of get involved?
I guess through doing things like this and sort of promoting our story, really. So I think the kind of value of us all connecting as a network and sharing innovation, sharing good ideas. So I think a bit of sort of promotion around the good stuff we're doing, which we're keen on doing, raising awareness, bidding for awards where they existed. So I think kind of just looking to raise the profile of we're a pretty, we're not a large organisation, and but I think for us it's particularly important to just sort of shout about all the great stuff we do.
It is, and look, it isn't a competition. I mean, I'm particularly proud of being from the northwest of England, and people would have looked at Moorland Bay, but for you to have impressed and those 7 hospitals to have been openness, I hope, and as we've seen in other sessions, the openness that people are sharing and adopting. There's been a change because there has been so much noise, which is why the Fabulous Academy was started, was to be able to help channel some of those shares and the real-time adoption. So thank you for taking the questions. There's a couple of questions coming in, if I may post them to the panel, and then I'll pick back up with you. So Divine's got a couple of points. Has there been any issues with the robot not working, given the challenges in pathology?
Okay, I can pick that one up, Shane. When we implemented the robot, we babysat it, I think probably is the best way of phrasing it, for a couple of weeks. All of the testing for the swab testing is done in our own labs. So we were able to work very closely with pathology to make sure that what was going in at the front end was what was coming in at the back end, and the report was going back correctly. And again, I think the amount of watching of a robot, it is hypnotic, I will say, but I've watched that robot for many hours on and off. So just to ensure that there are no glitches, should we say. The antibody testing is done by a local hospital, Preston Hospital, or Lancs Teaching Hospital rather, but we've had pretty well established lab-to-lab links between those two. So The robot still thinks it's just talking to our local lab, and our local lab hand off to the Preston lab as required. So those sorts of routes have been in place for a number of years. So that was fairly seamless. And the lab have increased their capacity as testing requirements have gone up. So we've not had any lab issues. But as I say, we did a bit of babysitting right at the start, and we have alerting set in place as well, which I maybe should have mentioned, so that if any of the results are queued for any length of time, whatever, that it will alert us to any technical bottlenecks rather than admin bottlenecks in the system. So touch wood, it's been relatively seamless.
I mean, one has to acknowledge, and Colin, you said it right up at the start, Steve started this journey with the team a long time ago. I know from the privilege of having met many of you, from executive to walk into many of the frontline departments and into the community as well. You've got a great open culture across Moorland Bay. Marc, I know from having spoken to you in the past, the ability to work with suppliers, but also do your own work around that testing. You're very used to making sure, and we are in pathology particularly, we're very careful about monitoring and making sure things are right. But it seems evident to me that, that openness across your system, that team working that has been built over a long period of time. Laura touched on it about, I think, multi-level leadership. It's amazing to hear how you reduce the stress on the staff, how that's been able to allow people to contribute by thinking. And I think that's something that we can't ignore in our systems when there is pressure, that sometimes the wrong types of behaviours have held back organisations and have caused, negative things to happen. So I have to compliment the team on that openness, and I hope that comes across to the audience. The audience is being a bit quiet this morning, but if I may, I don't know if I can delve a bit further to anybody on the panel who'd like to pick that up. What's it like working inside that leadership culture, and how do you think you contribute to it as individuals?
Yeah, thank you, Shane. I mean, I think for me, the health service is all. It comes back to the point that you raised before. The health service is all about people. It's all about people looking after people. That is. It's not shiny stuff and computers that are the important thing. Although we can't do our jobs without them, it really is about people, and it's about getting on with people, getting the job done, having at your core. Some key values and principles, and for me, all my career, it's been really important to be open and honest, and in different spheres. I mean, do you know what? I remember in the bowel cancer screening service, we had an early discussion 12 years ago. What we're going to do with our data? Are we going to analyse our data? Are you going to recognise Dr. A versus Dr. B? And we went straight out and said, no, names on the doors. It's the data is the data, and actually that kind of view rippled through the Northwest really very quickly. That kind of openness and honesty. And I think as an organisation, and I guess this is seen right across the NHS. Our organisation has come on leaps and bounds over the last few years in terms of connectedness with people, how we treat each other, how we work with each other, and it's about having those shared values, principles, shared goals, and go on a journey. And as you say, ditch the pride, ditch the ego. If you're fortunate to do some good stuff, make sure you share it. But actually, be humble and appreciate that. We're not going to generate all the answers in our area, so work with our friends over there and share their developments. So I think that way of approaching professional life in the NHS and moving forward, I think it's the human principles for me that are really important.
I think it's courageous, if I may say. And I mean, it's been my privilege to walk the wards with Aaron before, and I understand that culture comes from not just the top, but from the front line as well. And I do compliment you about that openness and encouragement. I mean, the practical things I took away from the presentations this morning about it being a real people service, and those lovely quotes and comments about it actually being a wonderful experience of this thing that you've created, the kind and compassionate. I mean, it is quite hard as human beings when we've got our own pressures, when we are in a quite a intense situation that is sustained. And I mean, if I may, just to explore, I'm fascinated listening to you all, and I know the logistics of where people are based and those sorts of things. How do you find as a team that you support each other? How do you draw strength from each other? Because the positivity that's come across is the evidence is in what you've done, the example that you talked about this morning.
Andy, do you want to pick that up?
Yeah, thanks, Colin. How do we support each other? I think it's led from the top. You know, Aaron, who you've met, Shane, he's very much into compassionate leadership. He chairs a bullying and anti-bullying harassment group for the organisation, and he sort of sets the tone. We've got a behavioural standards framework which lays out how we should speak to each other. Everybody should be treated with respect. We kind of embrace that into our department. We're very open to communicate. We meet 2 or 3 times a week, and we have quite an open culture of sharing problems. And we absolutely don't have a learning culture. You know, it's all right to get something wrong, and it's at those points when we collectively learn and examine what might happen, what could we do differently, how could we help each other. I think that was important too through the pandemic. Back in March, it did feel at times, not sure what the right word could be, but it was quite frightening for some people at times, and sometimes the workload was immense. There were so many things happening at once. I think just about everybody in our sort of leadership team worked right through Easter getting things set up, and it was that point where we did work well together. I think we're a close team. It was easy to ask for help. I think we got good clear directions, a good command centre set up quickly within the organisation, specifically for COVID, where we could escalate issues and where there were pressures we could get prioritisation from them.
That's great. Andy, thank you very much for sharing that. I've got a couple of questions coming in, and I'm just going to keep an eye on the time as well. But I would also like to take the opportunity, while I remember, if I may, the amount of shares and effort that Moorland Bay has given to the Fab Academy over the last few years. And, you know, I hear humbly, I think it was Marc said before, you know, we are a little trust in the Northwest. I don't think that's relevant. I think what's fantastic is you having the courage to speak up and share what you're doing. It's obviously not just making people safe and feel good and delivering it locally. It is having that national, and today being on this platform, hoping having national and international effect. So if I may, I'm going to come back to Divine posted a little while ago. This is really brilliant innovation and absolutely needed, and hope it can be rolled out for other tests. For patient-centered care, all results need to be available to the patient in a timely manner. Is there any plan for a wider test rollout? What adaptive processes have been made? And does that mean there has been, I think it says, does that mean there has been no feedback? And if I may, I'm going to include Jennifer Knowles' comment. Is there any scope for a wider rollout? If I may give that to the panel.
Yeah, I think there's lots that we need to do, and what I would say is that there was a great call to arms that everybody recognises back in February and March. You know, there was a unified problem faced by all of us, and everybody came together to meet the challenge of the first wave of COVID. I think going forward, we're all working hard now to do the recovery and the transformation stage, and thinking of what we need to do as a healthcare service. And we've got 5 national themes in the digital strategy: supporting the citizen, supporting the frontline and workforce, integrating care, managing things effectively, and describing a new future. For me, the bit that is the most important is supporting the citizen, and that until relatively recently was not really in our thinking. And this is what we must do to release and empower our citizens. So we've got to be able to create citizens' records platforms so that they can get the records that they need, the test results that they need, the appointments that they need in the palm of their hands in a phone. They need to be empowered to be able to book their own appointments or to modify appointments. They need to be able to message back into to the team as and when needed. We need to stop being mean and recalling well people back to hospital every 3, 6, 9, 12 months, because do you know what? That's what we always did since 1948. So for me, the thing that we'll get greatest value for out of digital innovation is supporting our citizens and empowering people to be in charge of their own care, be in charge of organising their own care, being able to access healthcare professionals and information when they need. So I think that's absolutely critical. We're working on that in Moorland Bay. We're working on that in Lancashire and South Cumbria, and there's lots of areas working on that as well, using different ways of meeting those demands. But for me, the principle is we've got to support citizens and empower them.
Fantastic. Does anybody else on the panel want to add to what Colin said there? You've done a great job, Colin. Oh, sorry, who's that?
It's Andy.
Hi, Andy.
Can we expand it? And yes, we could if there were further tests that needed to be automated. But the robot, there's a lot of demand for marketing skills building these robots, and some of the platforms that I've shared with you, we've been sort of dipping a toe into e-booking. So we could go get the first patient who booked her gynae appointment through an NDL form, and that's the first step into the patient portal. So that's something a bit richer to look into. But I do see a big feature for the robots or virtual workers. It's interesting to watch Marc's little army friends scale up. I think at the moment when it's really busy, it's 3 of them now, 3 robots working side by side, processing through this.
I mean, it does demonstrate the immense potential for the future, doesn't it? And I think as an industry, as a combined supply and user industry, we are pushing the boundaries of the possible. There's lots of talk about artificial intelligence and machine learning. And I know I've had the privilege of being with Roy Lilly on debates with senior people in some global IT companies who are saying, actually, we're 40 years away from true artificial intelligence. But these are the sort of examples that you've shown that here we are live in a pandemic. We can do something that's local, support our population, make real change, and then scale it. And I'm sensing, having known the journey of the last 20 years around that region, and knowing some of the aspirations in the ICS, STP, and with your neighbours at the moment. And you talked before about the example of sharing with the tests between East Lancs. I know there's a bigger region of you working. I know some of your work, Colin, clinically about standardising processes across the whole region to support millions of patients and citizens. There is a trend, isn't there, of actually bringing this together, being more open. But there's these short, very sharp steps that you've described this morning.
Yeah, there are lots to do. I mean, I honestly think that work at the citizen interface is really important. But you know, one of the things that we brought today, use of robots. I mean, there's massive opportunities with this kind of technology, and basically what we need to do is to look at very high volume, repetitive processes that consume and chew up your workforce, and we can release our staff to do other things by clever programming of robots. So even if it's a simple process like making sure all your clinics are cached up for that particular day. I can recall Marc did some good work for a screening midwife who had a devil's own job trying to scoop up results out of a national screening system that wouldn't talk to any other system. And one value of robots is that if you haven't got interoperability, you can scoop up data out of one system and put it into another. Now, Marc made a nearly half a day job for a digital midwife into a half-an-hour job, and it really improved her life. There are massive opportunities in back office, HR, finance issues, paying the bills. I'd really like to be going into primary care, because I'm sure that there must be loads of really difficult processes, either clinical or admin, where if we can look at applying robots to some of those processes, we can make people's lives a lot easier. So I think there's great opportunities for this.
Well, all power to all of you, and I'd like to take this opportunity to thank you very much, for, as I said, for the preparation, but also for having the courage to also step up and share. Well done, and congratulations on all the work that you've done. I think it is, Colin, picking up on your very last point, the opportunities are absolutely fantastic, and well done, and I wish you well with embracing them. We wish you well with the next phase of this winter. We know that the pressure has already started, and you know, as a nation, we're looking for all of you as leaders and delivering of healthcare for our citizens to look after all of us and all of our families. I can't stress that enough. But genuinely, thanks for supporting Fab Change Day. Thanks for the Academy of Fabulous Stuff, all the work that you do. Please continue to share with us. Thanks to our audience for tuning in. We're going to move to our next session now. Enjoy the rest of your day. I hope you were able to get into some of the other sessions. Thanks for tuning in early this morning. Well done to all of you. So my thanks to Colin, Andy, Melanie, Laura, Rob, and Marc. Hope I haven't forgotten anybody.
Thanks ever so much, Jane, and thanks for the opportunity. Pleasure as always. Take care.